Can I have your attention, please? Welcome to the University of Waterloo and the Waterloo Smarter Health Seminars. I'm Shirley Fenton, Managing Director of the Waterloo Institute for Health Informatics Research. Thank you for joining us today for this seminar celebrating the University of Waterloo's 50th anniversary. I'd like to welcome our web viewers and the Ontario Telehealth Network sites that have joined us today as well. Just so that you know, this seminar is being recorded and is being broadcast over the web. We ask that you hold your questions to after the seminar presentation is finished so that we can get a real or virtual mic to you. A very warm welcome to our guest speaker, the Honorable Michael Kirby. And a special thank you to our seminar sponsors, the Center for International Governance Innovation, the Faculty of Science, and the Provost Office at the University of Waterloo. A very special thank you as well to our seminar series sponsors, which you see on the screen behind me: Borden Ladner Gervais, McKesson Canada, Healthcare Information Management and Communications Canada, and Smart Systems for Health Agency. Before we begin, I just have a couple of announcements. Our next seminar in this series will be on Wednesday, October the 24th. Our guest speaker is Dr. Peter Norton from the University of Calgary. He is an expert in patient safety, and the topic of his seminar is "Why Not Safer Healthcare Now?" Well, we're beginning our fall term. September at Waterloo is all about new beginnings as we welcome new students and faculty to our campus. This seminar series, celebrating the university's 50th anniversary, is looking forward to new ways. The anniversary theme is "Why Not?" These seminars are dedicated to this theme and explore different questions related to health informatics ideas and innovations. It challenges how we do things now in healthcare and looks to new and better ways. So the agenda for today is as follows. Professor Dominic Covey, Founding Director of the Waterloo Institute for Health Informatics Research, will introduce our speaker. Michael will then speak for, I don't know, how long, 45 minutes or so. We'll ask you to hold your questions to after Michael's presentation. Please signal that you have a question and wait until we get the microphone to you. Please position the mic towards you as you speak. And we welcome questions from the web and the teleconference viewers as well. So may I introduce to you Dominic Covey, who will introduce our speaker.
Well, I've had the privilege in the past of reading what Mike has written, and I've always been impressed by it. And we've finally been able to get him here, so that luckily we got you before you knew about your most recent thing, or we would never had you here at all, I'm sure. But particularly the report that he wrote back in 2002 has been a real landmark in the area of healthcare reform. And just the last couple of days, I went back through the recommendations volume, and it was sort of like weird because a lot of the things that I read, I said, well, we're doing that. And I realized that this was written before we were doing that. So I guess what you have as one of your greatest credits that can be given to you is that much of what you've suggested, minus a few things, has been actually implemented. I mean, that's a real remarkable outcome and something to be extraordinarily proud of. Michael's a professor in the School of Business Administration and Public Health at Dalhousie University before he got into government. He's a faculty member at the business schools of the University of Chicago and the University of Kent in England, and actually worked in the private sector as well for a market research firm, being a senior VP at Canadian National and Goldfarb Consultants. He was a member of the Senate, and I'm sure you've all heard of him from there, from 1984 to 2006. He has been chairman of standing committees on social affairs, science, and technology. He wrote the famous report Recommendations for Reform, and under his leadership, the committee produced 11 healthcare reports, a real source of information, including the first ever national report on mental health, which has now dragged him into a wholly new way of undoing his retirement to the great disdain of his wife. And if luck, we had gotten early enough to us as well. So interestingly, Mike has a bachelor's and master's in mathematics at Dal and a PhD in applied mathematics from Northwestern University. In 1997, he received an honorary degree of Doctor of Laws at Dalhousie University as well. So he comes to us very well qualified, although after meeting them today, I asked for evidence of these claims, and so far I haven't received them. So take all of that under advisement. Welcome to you, Michael.
Thanks. Thank you, Dominic. I'm delighted to be here, and yes, I'm short, or else this podium is very tall. I can't tell which. And don't worry about it. I'm not going to talk for a prolonged period of time because I'd much rather answer your questions. But recognizing that this is the age of short attention spans, which is why we've gone from the 60-second commercial to the 30-second commercial to the 15-second commercial, I thought what I would do is begin by giving you the 5 points which I would call the executive summary of my speech. Then you can either leave or fall asleep, and I'll go ahead and prove the points that I want to make. The first point is that technology is merely a tool. It's not an end in itself. That is generally not the belief. It's my experience of people in the IT business, but I think that is a fact. Secondly, technology's got to be used to achieve a specific end of a restructured healthcare system. And therefore, you first have to decide where you want the healthcare system to go before you get into the issue of how do we use technology. That there is no sense using technology unless you know the end that you want to achieve. The third point I'd make is that any restructured healthcare system really needs to have two characteristics. First, it needs to be oriented around the patient, with the patient at the center, not the way the current system is organized, which is organized around the service providers with the doctor at the center. And secondly, the only way you can ultimately make best use of health human resources and the money you put into the healthcare system is, in fact, by doing what is typically called in the news media primary care reform, where you move from the practice when I was growing up of the single isolated GP to the group practice, which is not just a group practice of doctors, but is multidisciplinary. It has nurses, it has psychologists, in many cases it has physiotherapists, and so on. And that's the end to which technology ultimately must be used. The fourth point I want to make is that the reason that it's so hard to get electronic health records, but IT technology in general, implemented in the healthcare system is because of the massive amount of resistance that exists. Now, it exists in part because there's 1 million people employed in the business, and therefore trying to reorient the system is difficult. It exists in part because, I'll talk a little bit about privacy laws. I know we have a privacy expert here, and I promised to say something to offend him. So that's part of it. The second reason is that there's huge resistance on the part of service providers, doctors, nurses, everybody else that provides healthcare services. There's huge resistance on, and by the way, government bureaucrats that think they run it. And I say think they do because, in fact, they don't. But that's not what they believe. Huge resistance on the part of everybody that now has power in the system to be willing to make changes. And finally, there is a money issue. There is a shortage of money. But as I'll point out later, I wouldn't put another cent into the healthcare system unless I knew that money was going to be used to change the system. That merely spending good money after bad, dumping more money into an existing system that doesn't work very well, is wrong. And finally, my fifth point would simply be to make the observation that a lot of people who are big proponents of e-health, including a lot of people in the business, in fact, have been one of the problems in ultimately getting e-health adopted. Why do I say that? Typically, and I say this whether you're in the public sector or private sector, it doesn't matter, the people who propose the adoption of new IT technologies always do two things. They over-exaggerate the benefits by a lot. They underestimate the costs by a lot. They think that if you build a better mousetrap, somebody will use it even if what you're trying to do is not, catching mice has nothing to do with what you're trying to do. And frankly, they're so enthralled with their new toys that they somehow think everybody else ought to be enthralled with their new toys. And the reality is that the big obstacles to implementing IT technology in the healthcare sector has absolutely nothing to do with the toys. You guys can go invent the toys. We know that. The big obstacles are all driven around psychology, power structures, degree of organization, the way human beings interact with each other and interact with the system. And so I say that just because I was a little concerned that given the nature of the Institute and given the nature of this series, people would begin with the premise that all the news one hears about e-health is by definition good, and that it's only dumb, non-techie policymakers like me that have prevented progress from being made. So I think that a fair bit of that blame rests with the IT community itself. Let me just point out to you, though, why I think that the IT situation is important. And I just want to tell you about two news stories that have appeared in the last couple of weeks, which I think typify the best and the worst of the Canadian healthcare system. There was an article in the Globe on the advances that have been made by people with AIDS, HIV/AIDS, who noted that Canada leads the way in providing drugs that significantly expand the lifetime of people with this disease. There is a classic example of Canada being both a social policy and a scientific policy leader. On the other hand, about 3 months ago, there was a report by the Conference Board of Canada which showed that fewer than 1 in 4 primary care doctors, family practitioners, use electronic medical records to keep track of patients, and that 1 in 4 is in fact the lowest percentage in all 23 OECD countries. And indeed, of the countries studied, Canadian primary care physicians were the worst at having the ability to access and use information generated and stored electronically. And so I put that in perspective. On the one hand, you have the huge progress being made on something like HIV/AIDS, and on the other, you have the very, very backward view with respect to the way information is stored and ultimately information is used. And yet, you know, what's odd to me is that we live in a world where information technology is everywhere. I mean, go to your local pizza joint. I buy enough pizzas that the guy actually knows what I want by the time I call up to order my pizza. You know, you can now get your boarding pass electronically at home without even having to go and stand in line to get that. And yet, what happens when you go to a doctor's office is the very first thing typically the nurse does is she pulls out a paper file from that long list of paper files that she has. I mean, it's hard to imagine the way other industries have adopted technology, and yet the healthcare industry is not. And it's not unique to the issue of the patient health record. When I first got involved in healthcare some 7 years ago, I asked what I thought was a logical question, which is to a CEO of a big hospital, what's it cost you to do a hip replacement? Well, he didn't know, so I tried something easy. I said, what's it cost you to do a tonsillectomy? He didn't know that either. And I rapidly discovered that this man was running a service industry. And by the way, I'm going to use business talk here today only because the reality is that healthcare is a service business. And in spite of what Roy Romano has said in relation to all of the recommendations that our Senate committee has made, it is a fact that he used the following expression. He said, healthcare is not a business, it's a moral enterprise. Like, my dad was an Anglican minister. I know what a moral enterprise is, right? The healthcare system is about providing service to people, quality service provided as efficiently as you can by whoever can meet those first two tests. There is nothing moral about providing healthcare. It's got to be thought of as a service business. It's a big business, and we've got to find a way to restructure it. The reality is that hospitals are impossible. Hospitals, now they've improved in the last 5 years, but the reality is that most big hospitals have very, very poor information systems. What they do is they get an annual budget from the provincial government which says this is how much money we'll give you for the year, and then they're expected to manage within that budget. By the way, think of any other service industry that begins with a revenue source and has no idea how many customers they're actually going to get, right? But then we do something else to hospitals. We say, by the way, you are obligated by law to serve everybody who comes to your door. You can't get to the 11th month of the year and say, by the way, I run out of revenue, because if there's still people coming to your emergency room or people wanting to do things, you have to do it. So we have the ridiculous situation in which a huge company, let's face it, $1.5 billion in the big hospitals in the major cities in the country, not only don't know what it costs them to provide a service, and therefore, by the way, when they cut the budget, they have no idea what the implications are going to be. They are also compelled to continue to provide service even after they run out of money, and then they run a deficit, and then the government says it's your fault that you're in a deficit. The reality is a whole lot of the deficit issues have absolutely nothing to do with bad management, but everything to do with bad initial allocations by provincial governments. I mean, they misjudged the revenue. And indeed, what do provincial governments do? It's important to understand their role in all this. What provincial governments do is they, by the way, have no management information either. What they do is just look at how much money they're going to give a hospital. So they say to themselves at some point, well, you know, God, we got to knock $10 million bucks off Hospital X. They haven't the foggiest notion what the impact is going to be. So what they really do, and by the way, politicians, and I've been one, politicians get very upset when you say this. What cutting the budget really does is it rations the supply of healthcare services. Now, I was at a conference where I was asked to speak, chaired by one of the provincial premiers, and I made this observation while he was standing right next to me. I couldn't quite see the look on his face, but I'm told that he wasn't too happy about the simple observation that let's stop talking about cutting hospital budgets and let's start talking about what we're really doing. What we're really doing is we're consciously, deliberately rationing the supply of healthcare services. The problem is you can't sell it. If the public thought you were rationing the supply of healthcare services, they'd go ballistic, and they would correctly say put more money into it. And finally, we have no way of knowing what the most efficient way is of providing any service because we don't know what they cost. So what did the Senate committee suggest? We suggested a very simple change. We said instead of giving hospitals a global budget and doing it that way, what we want you to do, governments, is we want you to pay each hospital for each service that they provide. I mean, set the standard. This is what you're going to pay for a cataract. This is what you're going to pay for a hip replacement, whatever. And when a hospital does that, you send them the money. I point out, as this is very hard to do because you can't figure out what the cost is until you get the management information system. But in theory, not just in theory, in practice, by the way, hospitals in large parts of the rest of the Western world do that. But let me tell you what that does to all kinds of things. First of all, it allows the government or the regional health authority, or a LHIN, as you call it here in Ontario. A LHIN is a regional health authority with no power in contrast to a real regional health authority. What it does is two things. First of all, it allows them to say, okay, I'm going to do cataracts. And by the way, Ontario, to its credit, has done this. BC's done it in other areas. It allows them to say, okay, we want to do 10,000 cataracts next year. We're going to put it out to bid, and we're going to allow anybody to bid. We don't care if they're private sector owned, public sector owned. We don't care who owns it. What we want to do is we want to buy 10,000 cataract operations. When they started to do this, the estimated cost of doing a cataract operation was $1,500. That was the initial estimate. The last bid they sold for $450. So simply by putting an element of competition in place, by getting stuff out of big hospitals that shouldn't be in big hospitals because the overhead's too high, by creating specialized clinics that would just focus on specialized things, because as in any other part, think of any other industry, how do you reduce costs? You reduce costs by doing high volume, the same thing as frequently as you can, but the same thing repeated, which you can't do in big hospitals because big hospitals, by their very nature, are going to have a whole lot of one-offs. But you can reduce healthcare spending by leaving all the very complicated stuff in the teaching hospitals and moving the rest out. So it can be done. And yet, to get from here to there requires the two things that we don't have. And what it requires is, on the one hand, information on the cost associated with treating an individual patient, which I'm going to call today an EHR, or an electronic health record. And the second is some understanding of the other costs of running the hospital. And yet, trying to get from here to there is incredibly complicated. I just give you a couple of numbers that will just sort of stagger you. There are roughly 500 million lab and radiation tests done in the country every year. There are 400 million prescriptions completed every year. By the way, almost all of the requisitions for the lab and radiology tests and almost all of the prescriptions are handwritten, and in many, many, many cases illegible. And it's difficult, not difficult to understand, therefore, why you get, in fact, errors in medicine. I mean, look, it would be, if I wrote it, you couldn't read it either. I'm not dumping on doctors. My writing's illegible too, even to me. But the reality is that if it would, you reduce errors. There's lots of evidence to show you reduce errors dramatically if, in fact, you did the thing electronically, so you wouldn't have those mistakes. But in any event, if you add up all the prescriptions and lab tests, you're talking roughly 1 billion transactions a year, largely done on paper. I mean, it's hard to imagine any other industry. Keep in mind, this is a business model. This is not a moral enterprise. That it's hard to imagine any other industry that would do 1 billion transactions based entirely on paper. You cannot address the big concern of Canadians, which is the wait time problem, until you get an effective electronic health record and an effective management system. The reason is that it was last year Ontario's Auditor General's report estimated that 10 to 20% of the imaging tests, there's 70 million imaging tests ordered in Ontario every year, that 10 to 20% of those are wasteful, duplicated, not required, and that's in part because the individual ordering them has no way of knowing what has been done before. More importantly, a lot of these errors lead, in fact, to preventable deaths. The latest study says approximately 23,000 Canadians die each year in our hospitals. Always interesting that it's actually in many cases safer to be at home than in the hospital. But that's the reality. And they die from preventable deaths largely because of drug interactions that people missed, inappropriate medications, or other forms of failures in healthcare coordination. And if you want to put that 23,000 in perspective, by the way, that's 8 times the number of people that died in the World Trade Center buildings, and we're doing that every year. I mean, when you put it in that sort of stark reality, 23,000 doesn't sound like a big number. If you look at the reaction to the World Trade Center and say, we're doing that in this country, and preventable one. I'm talking specifically about errors that have led to death and have been concluded that in fact they were preventable. So why am I in fact in favor of the electronic health record? I'm in favor of the electronic health record, the individual patient record, precisely because it is the cornerstone piece of information that you need to run an information system. How you use it and the way it's used and so on requires a lot of adjustment, but the reality is, in my view, it's the critical piece of information. And yet what happens? What happens is that it can be done as encrypted, it can be done as a secure piece of information, and yet there's a lot of concern about it on the basis of privacy. There's a lot of people who would argue that they're concerned about the encryption. It's not going to be properly done. It's going to leak out to employers, and on and on. And yet the practical reality is that in many ways an electronic health record is actually more secure than a piece of paper, because if it's in a piece of paper in a file and somebody loses the file or whatever, it can go anywhere. The reality is an electronic patient record requires that only people with access to it can get to use it. But let me be very clear. Just building the mousetrap of an electronic patient record will not solve the problem. It's a necessary ingredient. If I go back to my mathematical days, it's necessary but not sufficient in order to be able to accomplish what you want to accomplish. Because clearly what you have to do is figure out how that actually fits into the way the healthcare system runs, how it fits into the issue of workflow, as much in a GP's office or in a hospital administrator's office. We have to be very careful not to fall in love with the mystique of an EHR unless we're prepared to understand the way, in fact, it's going to be used in the marketplace. And that is actually one of the biggest single problems, and it's why I say technology must always be viewed merely as a tool and not as an end in itself. The end in itself is restructuring the healthcare system to treat more people faster with better quality. The end is not to build an EHR. And yet, if you talk to the people typically running technology programs in the healthcare sector, that's very much where they come from. And just to sort of put in perspective the kind of rhetoric, they think politicians exaggerate. You ought to read IT claims. The rhetoric that is attached to the EHR. A year or so ago, there was a study done by Booz Allen Hamilton, one of the consulting firms that was obviously looking to get consulting jobs. Said the following are the benefits. I don't believe these, but I think you just ought to get some sense of what people are saying. The economic benefits associated with an electronic health record would be a reduction of duplicate and unnecessary lab tests. That would save $10.4 billion over 20 years. You would reduce duplicate and unnecessary radiological tests, $3.6 billion savings over 20 years. You'd stop adverse drug reaction events, save $48.3 billion over 20 years. And by the way, in addition to that, the benefits that they didn't quantify, you'd strengthen productivity, efficiency, and coordination. You'd strengthen health reform agendas, and you'd support the increased quality and safety and care practices. Now, a whole lot of that sounds like the guy from a traveling salesman out there in the old wagon days when he had the magic elixir at hand. Now, by the way, a lot of those things are true. Numbers are not true. I mean, nobody knows what the numbers are. That's why they put them in 20 years, so that nobody will be around. Anybody who agrees to the thing, well, they do it so that the guy that agrees to the thing will absolutely not be there at the end of 20 years to know whether it was right or wrong. So I mean, these guys are really good salesmen. But what they don't do, what I have yet to find anybody in the e-health field doing, is the following: saying, okay, go back to what I said at the beginning. What is our objective? Our objective is to make the system more efficient, improving care and shorter waiting times for people. Now, beginning from that, which is the end, okay? Work backwards up the system to tell me what it is needs to be done in e-health terms, in electronic information terms, to achieve those goals. Don't begin by telling me you've got this really neat thing which you know will help the system, except you really don't know if it'll help the system. You believe it'll help the system. And there's no real proof that it will help the system. What you have to do is to work backwards from the information needs in order to achieve the goal, ultimate goal I talked about, and work back up the system. And that's why, frankly, we have a whole lot of impediments to actually moving IT forward because of the kind of exaggerated claims I gave you from the Booz Allen study, and I'm not picking on Booz Allen. Any consulting company around would tell you the same thing. And let me talk just for a couple of minutes about some of the really bad and tough hurdles. One is the privacy issue. There's no question, by the way, public opinion poll after public opinion poll shows that Canadians are very concerned about the privacy of their health information. In fact, they're much more concerned about privacy of health information than they are about privacy of financial information, maybe because they don't have much financial information. But nevertheless, there's a huge degree of concern, justifiably, in my view. And yet, equally, it's true that in annual surveys which have been done by a number of survey firms, including ECOS several times in the last decade, they show that in spite of the perceived risks, 85% of Canadians are, in fact, in favor of electronic health records. They are now more and more convinced, as they use PIN numbers to pay Visa bills and to purchase stuff on eBay and so on, they are now more and more convinced that it is possible to have a system that is secure and will protect the information. Nevertheless, the nature of privacy laws is such that there's a whole lot of hoops you've got to go through to get an electronic health record in place, and in fact, some of the privacy zealots are still strongly opposed to an electronic health record. In fact, let me just digress to make an observation for a sec on the privacy issue. I happen to be a believer in the privacy of health information. I've supported bills in Parliament from it. I've argued about it in favor of it on several occasions. Now that I'm doing the mental health issue, I'm really troubled by the following problem. If you're the parent of a child, and let's give you a range of ages from, say, 16 to 30, child's living at home, child has a mental illness, you as a parent and the principal caregiver have no right to know what's wrong with the child. By the way, living in your house, you're the principal caregiver. No right to know what ought to be done to help that child. Because under privacy laws, once you turn 16, only that information can only be given to the child, and unless the child agrees, it cannot be given to the parent. For that matter, you're not even allowed the doctor's not even allowed to call the office and say, will you tell your son George that he's got to go to an appointment next Wednesday? I mean, it's that restrictive. That raises a very interesting dilemma for people, because the privacy laws are all based on the assumption that an individual would have the rational competence to be able to make the judgment as to what was in their best interest to tell their parent or not. In a great many cases, schizophrenia being the best example, and I say schizophrenia because it typically hits in the late teens, early 20s, the underlying assumption of privacy legislation, which is the rational decision maker, is in many cases not true. One of the things the Mental Health Commission is going to do, and we will be blasted by privacy zealots all over the country, but we're going to have to find a way to deal with that problem, because the reality is that the patient is a whole lot better off if the caregiver knows what the caregiver can best do to help the child than if the caregiver is told nothing. So privacy is a challenge. Second problem, which is actually a huge problem, is the problem of getting people who run the system, who are responsible for providing health care, to actually agree to change the way they do things. Because once you've all heard the claim that information is power. Once there's a reasonable spectrum of people who actually know the same information about the patient that the doctor does, automatically you have weakened the power base of a doctor-centric system, because the doctor is not only supposedly the source of all intelligence about patients, which is by and large not true, but they're also viewed in their own minds as also the only source of information. So trying to change a system that employs 1 million people is not easy, and we won't make any progress, real progress, on e-health until, in fact, we convince healthcare providers that they have a fundamental role to play and that they've got to be prepared to change the way they do things. If I look at the business literature and I go back and say, is there an analogy? I think there is. If you go back to the business writings of the late 1980s, early 1990s, the big phrases of the day were re-engineering the corporation, business process re-engineering, process innovation, all kinds of management consulting words that were designed to talk about the same thing, which is to change the way companies do things in order to make it a much more efficient business. And businesses all across the Western world have, in fact, done that. They have actually begun by saying, how do we have to change the way we do things, and then what role can technology help do in getting us there? You can't simply take the technology and graft it onto the existing system. The analogy I've always used there is that, as many of you know, the biggest single difficulty with organ transplantation is rejection, because you put the organ into a foreign body and a new body, and the body into which the organ has been put rejects it categorically. So, there is a huge graft problem when you do that. I will tell you, technology trying to put e-health into the existing healthcare system has a whole lot of similar analogies. There's this foreign body that ultimately decides it doesn't like it, and it rejects it. And far more attempts at e-health do that than in fact the opposite, which shows that which really makes improvement. I mean, the reality is that organizations, particularly big ones, hospitals, healthcare systems in general, are extremely complex. I mean, there's huge collections of people. Whether they're run badly or run well, the reality is that they really consist, particularly in the service industry, which is what healthcare is, a multitude, millions of interactions between people, processes, structures, and strategies. And therefore, trying to make change in such a system is not easy. And it's impossible if you begin with the premise that you're going to take a technology, graft it onto the system without the initial buy-in by the people who've got to use it. They will simply reject it and not use it. And it's particularly difficult in health because of a whole lot of rigid work rules. The healthcare system, by the way, is not really a system. It's a series of silos loosely interconnected. The only difference between the acute care system and the mental health system, but there is no loose interconnection. They're absolutely silos. But the acute care system, you have all these silos. What you also have is things called scope of practice rules, which in any other business would be called the things that preserve the monopoly for various classes of service providers. They would fail every anti-competitive test in the world, but the professions have got it for themselves, and they're not letting go very easily. And yet the reality is that the only way you can begin to pull all this together is to allow individuals like nurses or nurse practitioners to, in fact, practice to the full level of their competence and leave the doctors at the top doing the things that only their specialized training can do. And in mental health, this is colossally true. We pay under Medicare. The only mental health service you can really get from a professional that's paid for by OHIP is psychiatry. The reality is that the vast majority of help people need, of a clinical counseling kind, can easily be done by clinical psychologists and by social workers who are trained to do that kind of work. And yet what do? We say you can't, but public won't pay for that because it's not being done by a doctor. What we ought to do, because so few psychiatrists, we ought to use a psychiatrist for the only thing for the thing that only psychiatrists can do, which is the very, very difficult senior mental health patients. Now, if we did that, you wouldn't have the situation you have today. And I tell you, I should say my wife gets because I'm usually not there. We get better than a call a week, typically from parents or the spouse of a family member, and it was either a child or the spouse, who has a serious mental illness and is told that they will not be able to see a psychiatrist for a year. And meanwhile, there's nothing that can be done because the individual, first of all, typically they cannot. There are people who could not afford to pay for a clinical psychologist, even if that would work. And secondly, they can't afford to do it, or seeing a clinical psychologist wouldn't work because they're dealing very much with extreme and very sick people. And yet, trying to change what I've just said seems patently obvious to everybody, right? Trying to change that, the psychiatrists actually would agree with what I said. That's because you don't mind competitive pressures in a monopoly when you know you've got so much, you can sell all your business anyway, so it's not like you're going to lose anything, right? So they're in favor. Not quite the same for some of the other surgery specialties, but who love the concentration. And yet, do you think you can persuade any provincial government to do that? Well, isolated cases, some regional health authorities are now doing it. In some of the family practices in Ontario, they're doing it because OHIP has said you can hire a psychologist if you want to. But that's because OHIP now pays a group amount of money into this practice, and the people running the practice use it the best way they can, which is not having a doctor do well baby visits or listen or give a 45-minute session in counseling. So the resistance in the system to change is absolutely one of the hardest things to do. And in the end, I'm of the view that some of it's going to have to be done by brute force. When I say brute force, I mean you can no longer have a situation in which scope of practice rules essentially prevent huge progress being made in the system. Unless you think, by the way, it's just doctors. Let me tell you. I spent a day a couple of years ago, 3 years ago, looking at the labor contracts in a major hospital with different parts of the nursing profession. They are the most rigid work rules I've ever seen. They reminded me, as I said to the hospital CEO after I'd read them, I said, they remind me of the fact that all the students here are too young to remember, but at one point Canada had steam trains, engines where you had to put coal in to create steam to make the train move. And the firemen on those trains had such an ironclad contract that when we switched to diesel trains, we actually had to keep a fireman on the diesel train until they all retired. So I didn't do anything, but the work rules required that you do that. I got to tell you, if you go into a hospital and try to get a nurse working on one floor to move to another floor in order to make a significant change, the work rules cause absolute chaos. So it is the most structured workplace you've ever seen, and you cannot change a workplace you cannot create change when those work rules are so structured. The fourth comment I would make with respect to the EHR and its difficulty in implementation is what it does to workflow, which is why you got to start and work backwards. What do I mean by workflow? I mean doctors and others in the healthcare system have a way of proceeding. What you got to do is not necessarily tell them to adapt to your new technology. It's to make the technology make their job more efficient by virtue of the way they do it. Whereas, in fact, typically what happens is we develop a new bell and whistle and we say, by the way, you got to change because that's the way we made it. Instead of saying what we're going to do is adjust it so that, in fact, it works well with you. And it reminds me, Mark Twain had a wonderful phrase which really, I think, applies to the use of e-health in the healthcare system. Mark Twain said, everybody's in favor of progress. It's just change they don't like. And essentially, in the healthcare system, that is exactly what the problem is. That adopting new practices, new routines is, in fact, not going to be easy. And, of course, the fourth problem is money. Everything in healthcare comes down to money, but, what typically happens is people begin by thinking money's the problem. Money, again, is just a means to an end. Like money's exactly like the sort of tool that e-health is. It's not an end in itself. And given how inefficient the current system is, and given the difficulty of getting providers to change the way they do things, I've always had trouble understanding why governments would dump a whole lot of money into that system other than the fact that the public will think that they're actually doing something. Whereas, in fact, all you're doing is raising salaries, typically. I'll tell you an interesting comment. The last time the federal government, back 4 or 5 years ago, last time the federal government gave a brand new, gave the provinces a whole lot more money under the cost-sharing programs, 90% of that money went into increased salaries for people already in the business, didn't create a new job, didn't build a new hospital, didn't create a nursing thing, didn't do anything except made the people in the business better off. Now, if that isn't, that's what so appalled me about it. I mean, I pleaded with the Prime Minister before he did it. I said, you don't give them a cent unless they agree to make changes that make the system more efficient. Instead, he gave it, the money was given by Paul Martin in an unrestricted manner. And the result was obvious that the money just, the next union negotiations, that's where the money went. So money is important, but money in and of itself won't do anything. You've got to use the money to buy change. And that requires the political courage to take on very entrenched interests. And that's particularly true at the provincial level. It's less true at the federal level because the healthcare system is actually funded and run at the provincial level. And so, even on the electronic health record, I mean, the money that's been put into an organization called Canada Health Infoway, the feds have put $1.8 billion so far into it. about $45 to $50 a head. In the country, it's going to take about $300 a head to build it, so they're about 1/6 of the way there. But the reality is that, again, just investing money in e-health without getting people to do other things is, in fact, not the way to go. So having given you that sort of bleak scenario, let me just tell you, there are actually some good things going on in the country. I'm not entirely a pessimist. I describe myself as an optimistic cynic. And so I'm going to give you a couple of the optimistic examples just to show you that it's possible. You can now have, in a number of provinces, have an MRI digitally captured and sent elsewhere, where it gets ultimately downloaded for interpretation by a specialist. And in fact, one of the regional health authorities in Vancouver, Dominic's wife would like this because she's a radiologist. One of the regional health authorities in Vancouver has done the following. The radiologists didn't want to be on call to work at night. You know what they did? They went and contracted 2 radiologists in Australia, where nighttime in BC is daytime there, and they read the radiologist reports and send them back. So in fact, you don't have to do the on-call business, or you don't have to do the overnight stuff. The stuff gets done by equally qualified people. I don't think they've really publicized that that's the way they're doing it. But in any event, and I can understand why they wouldn't, because some people would be appalled. The reality is it's a terribly practical solution, it seems to me, to a problem. But it's very clever. That's the kind of creativity one has to be prepared to do. And so, we're going to have to be prepared to put a fair bit of money into changing the system. But more importantly, what we've got to do is we've got to focus on getting people to look at how the system can be changed before we put the money in. And even then, it's going to be a fight. Let me tell you that you try sitting in a Premier's office, a Prime Minister's office, around a cabinet table, whatever, and the poor Minister of Health comes in and says, I really need $100 million for e-health. And everybody around the table will look at him like he's certifiable. And they will say, let me get this straight. We got people out picketing because we got wait time problems. We've got people upset because they can't get breast cancer stuff on time. We've got other people upset because we're not paying for certain very expensive drugs. And you want to put $100 million into e-health, which isn't going to buy us a vote, isn't going to help a single person in the short term, and by the way, it won't. And so all the pressure in the system, and I got to tell you, it takes a huge amount of gumption for a province to be able to say, well, fine, we're going to put the money into e-health instead of the other, when the world is falling down around them. And the other problem they have, and this is true in the public sector and private sector, and I say this, I chair the audit committee of 3 fairly large public companies. I got to tell you, when the IT guys come in with their eyes wide open and they got gung-ho and the adrenaline's running, and they tell you, man, have we got something for you. And they proceed to list, like the Booz Allen study did, all these wonderful things that you're going to gain, and it's not going to cost you much money. You got to put a huge discount factor on that. I have yet to see one where the benefits are nearly as great as their spouse. By the way, also never finishes on time, but that's a separate question. And the costs are always colossally more. In fact, I've only ever seen one that came in within 10%. Typically, they're as high as 75 and 100% over the initial cost, which generally, by the way, wipes out all the benefits, even if the benefits existed, which they don't. But that's it. So politicians, they're not techies like some of the people in the audience. We don't know whether or not you're telling us or snowing us. And I guess the history would suggest it's more likely to be the latter. And so there's a huge resistance on the part of people like me who get involved in making these decisions. And I think a whole lot of the responsibility for bringing guys like me around rests with the people in the business. It isn't up to me to automatically believe what you're telling me. It's up to you to establish a track record that you do, that what you say actually happens, that you are capable of predicting benefits, that you do know what the costs are, and you do know what the timetable is. All the evidence I've had, particularly in the private sector, has been that doesn't happen. And so you not only have to get over the resistance among service providers to moving to e-health, what you've got to do is you've got to get a more trustworthy dialogue. You've got to get a degree of confidence between the public policy makers, the people that allocate public funds, and the people who are trying to persuade them to do things. Now, everything is not bleak, but that is the picture. Are there signs? I had a here, I didn't want to talk too long today, but I have here a list of probably a dozen really good examples in Canada where e-health is working in isolated examples. Yes, it's going to cost money, and yes, I'm a passionate believer in it because I don't think fundamentally you can ultimately change the healthcare system as we know it until you change the way hospitals are funded and move them into a competitive marketplace, publicly funded. You pay for it with your OHIP card, but it's publicly funded, and I don't care who delivers it. I'm not arguing the public sector shouldn't deliver it. I'm just saying I don't care who delivers it. It shouldn't matter. We're an insurer. The role of government in healthcare is to be an insurer. It's not to be a service provider. It doesn't have to be the service provider. But we're making some progress. It is going to take a lot of time. And the only way I know that we're going to accelerate it is to begin to build a demand from the grassroots up, which I think is going to come because of the wait time issue. I've had involvement with a number of designing wait time strategies for various provinces. And every time that we run up against the barrier that we don't have the information because we don't have the data, and we don't have the data because we don't have an electronic health record, that's one more argument for, in fact, proceeding to create it. And I think it will come. I think it will come probably faster than I thought. And more importantly, in the end, it really ought to come because I think the evidence clearly illustrates that unless we move into e-health in the kind of ways we've talked about, it really is a matter of life and death, and I think that more people will begin to understand that as time goes on. Thank you. I apologize. I just realized I talked longer than I meant to, but my wife says I always do that, so.
Does she listen?
No.
We did. Questions? We'd like to get the microphone to you and give you a chance to ask questions or make comments. So if you put your hand up, I'll try to get it to you. You got to put them on the spot. You can't get away with without being abused here. So there's one in the back there.
Yeah, and I'm not at all bothered by offensive questions because I don't think they're offensive, so that's fine.
I have a question. You're an institution, higher education institution, and I'm just wondering why governments can't have an elevated investment, like have a graduated investment in e-health, to start it in universities, in those teaching hospitals that are well enough because of private support, and try to show that it is successful and use that as a model to expand it around the country? Yeah,
that's a very good question. There are a number of, I would call them isolated examples around the country where that's happening. Let me give you an example. For instance, every senior in Saskatchewan has all of their medical records, all of their prescription records are now available electronically to any pharmacy and to any doctor, so that you avoid one of the biggest problems with seniors and medicine, which is inadvertent negative side effects due to the interaction of various drugs. And that's actually helped a lot. There are isolated cases around the country where this kind of thing is happening. But as I say, even if one were to decide one wanted to take the hospital here in town and make a case study of it, you have a whole lot of internal resistance to overcome because people are used to doing things one way, because you fundamentally change the power structure of the system, because, as I said earlier, information is power and more people get it. And it's the psychological side or the organizational side of introducing e-health that I think is the biggest barrier. It's a bigger barrier even than money. So the answer is I'd love to do it, and various places are trying smaller experiments, but not yet. I think there's... Over here.
Thank you very much. I thought that was a really interesting talk, and you hit a lot of very cogent topics there. One of the things that I've noticed about getting primary care on side is that it's a no carrot, no stick problem. There doesn't seem to be, for a practitioner, enough benefit to get in, sadly, and there doesn't seem to be any downside to not participating, which makes it very, very difficult to enjoy system benefits.
Right.
In a federated system, if you've got people who are allowed to not play, it will successfully defeat enjoying those system benefits. You said that you think that, I wish I could say what you were going to call it, something that would act as a stick. Are you suggesting that maybe legislation could make people
No, I'll tell you,
participate?
I'm a real believer that that you got to use incentives. And in fact, I'll tell you, the major recommendations of the Senate committee report were based on the following. We sat down and we figured out what was the behavior we wanted family practitioners to exhibit, then specialists, then hospital CEOs, etc. And then we asked ourselves the following question: what incentive would get them to change their behavior? So let me take a concrete example. We said for family practitioners, we want them to spend more time doing preventive medicine, which means they got to spend more time with the patient. We don't want them doing things that they do now just to get the money for the visit, like well baby visits, unless there's something really wrong with the baby, like a lot of the other, writing out prescriptions, all of that kind of stuff. So what did we say? We said the way you do that is you go to the family physician, you say, okay, you're gonna tell us who your patients are. We're gonna pay you a flat fee for the year to look after that patient. And the amount of the fee will depend on the age and the acuity of the patient. So it's not a flat amount per person, right? Otherwise, everybody would only take university students and nobody else, because they never get sick. I mean, unless they drink too much, they never get sick. And so you want to spread that out. Now, why did that change behavior? Because the minute you do that, the family practitioner suddenly is really in his interest to keep you healthy. It's really in his interest to practice preventive medicine, because if he does that, he doesn't have to see you as often, and therefore he can have more people on his list. Secondly, it becomes very much in his interest to move you to allow the nurses, the nurse practitioners, whatever other people they hire into this multidisciplinary, and that's the key, multidisciplinary group practice. It really becomes in his interest to do that, because if he only focuses just on the small slice of patients that really require his unique expertise, then in fact he'll be able to have a lot more people on the list, and the annual income coming into the clinic depends on the length and the acuity of the list. So that changes that behavior. For hospitals, we argued that we called it service-based funding, but so that you pay an individual on the basis of the service that they get. The reason for that was twofold. First of all, if you then had to cut the budget, you wouldn't be able to talk about cutting the budget of X millions. You'd be able to say, I'm not going to do this many hips, this many knees. I mean, the general public would, if they knew the cost of a particular procedure, would be able to take the cut and translate it into how much you really rationally supply, right? Which is what nobody in politics wants the public to understand. But if they understand that, you'll begin to solve the problem real quick. But more importantly, there's a huge psychological difference in having somebody walk up to the emergency room. Think about it today. If you go into an emergency room today, you are a drain on the revenue of that hospital. They've got a fixed budget, right? And you're causing them to have to spend that much of their budget on you. If you go in and you're a source of revenue, because what you're doing is they're going to get paid for treating you, the whole psychology changes. And I have tested that with probably 25 or 30 of the CEOs and that level people around the country, and they absolutely agree with me. And the proof of that, if you need the ultimate proof, the proof of that is the Cardiac Care Network of Ontario, which essentially is cardiac care. The reason you never hear about it in terms of waiting lists is that in 1992, very good friend and former colleague of mine in the Senate, Willie Keon, who's the doctor, the leading cardiac surgeon in the country who set up the Ottawa Heart Institute. What he did was he went around and got a dozen of the best cardiac surgeons in Ontario and said, okay, guys, we're going to go to a single list. We're going to do a common assessment procedure right away. Then we're going to funnel all the names into one place, and we're going to do a single list, and we're going to deal with people on the basis of acuity rather than on the basis of the fact that they happen to be at the top of a particular cardiac surgeon's list. The result has been that they have dealt with the cardiac cases are dealt with fairly. Why? Because the people in the greatest need get treated quickly. Sometimes, by the way, it means a patient in Ottawa may have to go to Hamilton or Toronto to get treated. And every time, the patient usually grumbles for about 30 seconds until the doctor says, well, I'm sorry, if you don't do it here, you'll have to wait your turn, and it may be 3 months. That has a tendency to put a very sobering impact on the patient who needs the heart surgery. Patients have to, we as Canadians, as individuals, will have to compromise too. But it's doable, and the heart surgeons proved you can do it. By the way, they've just done it in Alberta, exactly the same procedure with the orthopedic surgeons in all the hospitals in Edmonton and Calgary. And the only difference is sometimes you have to fly someone from Edmonton to Calgary or the other way around. But I got to tell you, when the patients, objectively we sit here now and we say there's not a chance I'd want to have to do that, right? You're sitting there waiting for a hip replacement and you're really suffering and you're told you can go up to Edmonton from Calgary and get it tomorrow, or we can get at you in a few months from now. Trust me, the flight disappears. I mean, they do the flying, right? I mean, they give you a medevac thing. So Canadians have to change. By the way, if you live in Peterborough, if you live down in Niagara, even under today's system, you're going to have to travel to be treated. So why is because you happen to live in Toronto, if you live here, you have to travel to be treated if it's a serious thing. So why, if you happen to live in a community with a health science center, a medical school, why should you not have to face the same risk of traveling that other people have to face? So I'm hugely unsympathetic on that, and I also absolutely believe that once people understand the real trade-off because they're really sick, slam dunk.
We hear criticism just about everybody's medical system, whether it's ours, the Americans, the Brits, really doesn't matter. Is there anybody out there who's close to getting it right?
The French are pretty close. The American system, by the way, there's absolutely nothing you can learn about the American system for the following reason, other than the fact it's the most expensive in the world. If you are wealthy, it's the best in the world, no question. You can buy anything you want and you can get quick service. If you are not, if you have to pay for it out of pocket and you don't have the money, it is close to the worst system in the industrialized world. The interesting thing is, to take France as an example, Germany as another example, they have a system, and I'm going to sort of describe it to you in the Canadian context, okay? I kind of do a little bit of a transfer here. They have a universal system like we do, but they also have what I would call a parallel private system, which means that the universal system treats everybody, and no matter what your income level is, you could use it. Otherwise, what you do is you get treated, you buy private insurance and you get treated that way. And then, of course, the argument is, well, what will happen is that all the good doctors will gravitate to one system and not to the other. And the way they've corrected that is very interesting. It's exactly what we recommended you do here. In order to get a license in either of those countries, you have to commit yourself to spending 2/3 of your time in the public system. And so the result of that is that there's no such thing as the best guys are never in the public system, right? But what does it do? If you really think about what it does, is it pumps a whole lot more money into the healthcare system. Because the people buying insurance and so on are pumping a whole lot of money that's not coming out from tax dollars, it's coming out of the pockets of individuals. So the way they've dealt with a universal system and needing more money is not to go back to the taxpayers and ask for it. It's to say, fine, if you want to buy private insurance, go ahead. You can get the service done. That's your call. Australia works approximately the same. And we'll protect to ensure quality and other things in the public system by constraints on workflow. So is it possible to do? It's absolutely possible to do. And that is it. I did a slight variation, but that's essentially what we recommended.
We have a question from the people online. So.
Okay.
This is from Corey on the web. Do you think that Canada Health Infoway should look at some of their funding envelope on business process improvements and system change in addition to just technology?
Absolutely. In fact, I think Canada Health Infoway is actually, particularly since Dick Alvarez took over as the CEO, has done a really good job. But the reality is that that the other side of the coin, which is not just develop technology, but in fact look at the words that you just used or the online viewer used, which is business process systems. That is absolutely critical, and we are putting essentially nothing into that. By the way, we're also putting close to nothing, not quite zero, but close to nothing onto mental health either, because mental health is still the orphan of the system because of the stigma that's attached to it. I don't want to get off onto my usual pitch for mental health, but I don't tempt me, or I will. In fact, I don't even need to be tempted. But but yes, they should be putting money there.
Okay. There's a question over here, and just a couple of people in the audience who come from our health faculty who have, I know, thought about this a lot, particularly with the issues of maintaining health in people. So I also challenge you to, if you would be willing to comment on these. Would like to have your comments. So you're next.
I'm actually from a math and accounting background, so I won't take that on. But I had it's twofold, my question. First, with regards to the behavior change you talked about, how do you know that with the doctors, if you were to change the system and give it on a per patient basis, it results in them practicing preventive medicine rather than trying to get the patients out of their office faster than they already do these days? I understand it would affect behavior, but how do you know it would be that way?
Okay, what you're really saying is when I said I wanted them to practice preventive medicine, why would they do that, right?
Well, what I was saying is I understand the reward system where you have an incentive.
Right.
But how do you know the behavior?
Oh, because the incentive from the doctor's point of view is to not have the same patient come back too frequently, right? Because if the same patient comes back too frequently, you can only see so many patients, and therefore your roster, your list of patients accredited to you would be smaller than it would be if you kept them healthy in the first place. So logic would say there's a huge incentive for them to keep people healthy in the first. And by the way, they've told me they would do that. But the logic is that if they didn't make any attempt to keep people healthier, the patients on their list would come back much more frequently, and therefore they would have fewer patients on the list, and their revenue depends on the number of patients on their list, not on the number of times they see them.
Second part of my question was, I know you talked about someone would have to start this initiative at some point. What do you think the role of the guys at the federal level would be? And I'm sure you would have some thought on that, having been there, considering the fact that, I guess, under Section 92, it is a provincial jurisdiction, and the fuss that the provincial guys came up with after the Canada Health Act, I guess.
Well, I'll answer that directly. Let's make an interesting observation for you. The two health reports, the original one on the acute care system and the one on mental health, I would guess 80 to 90% of our recommendations were directly in provincial jurisdiction. We have never had a word of criticism, never had anything but support from the provinces and territories, basically because what they saw us as attempting to do was help them solve a problem for which they were desperately seeking a solution. My only argument with the feds is that the unrestricted transfer of money with no strings attached leads exactly to what I said, which is increases in wages and salaries for people in the business. And it's very hard. I will tell you, I mean, I've actually gone through a doctor's strike when I was Chief of Staff and Secretary of the Cabinet in Nova Scotia, Chief of Staff to the Premier. A doctor's strike is about as scary a thing as you will ever put up with. And the beauty of the federal government imposing conditions on transferring the money to the provinces is there is no sense in the healthcare professionals getting mad at the province. They can get mad at the feds, but getting mad at the province doesn't help it because they know that if the province doesn't do what the conditions are, they won't get it. So I actually think the feds do people a huge favor by imposing conditions because they make it much easier for a provincial government to justify forcing changes on the system and let the feds take the flak. And politics is the art of shifting the blame, so that's a factor. Yes, go ahead.
Andrew on the web asks, ECHN, the Electronic Child Health Network, is serving the pediatric population of Ontario, about 3 million people. It is voluntary, and the doctors and parents both love it. It's not perfect, and it doesn't do everything it could do. It keeps growing organically. Slowly but surely, more and more doctors are using it. It was built and expanded gradually, in response to demand by users. What do you think about this kind of gradual, incremental approach versus the boiling the ocean approach?
Well, it's the only way to go. And indeed, I was talking to people here at the university today, to Dominic and others, about my desire to do that with respect to seniors' health, but particularly seniors' mental health. In the seniors' health care case, the family caregivers typically, it's not uncommon to find a spouse over 80 looking after an ill spouse, particularly with a mental illness, early stages of dementia and so on, with a mental illness. And I'm trying to find a way to reach those people, to give them the kind of assistance, peer support, various other things that right now there is no way to do it. And the way to do it is exactly what was done with the Children's Health Network here in Ontario, which is actually very good. And it's simple. Like, it's not, you didn't build a Cadillac. You built, a Chev, maybe even a VW, right? But you built a system that was designed to meet needs, and they keep improving it year after year, and that's great. But you can't begin with the global stuff. It just doesn't work.
It might be good news to note that for somebody that the ECHIN is actually included in the new e-health strategy as a tentative, at least interim solution related to some kind of an electronic health record.
Oh, really?
Yeah, it's been Stady Brown is the one that's promoted that. I don't know if that's good or bad, but that last time I read one of the problems we have, we don't know what this strategy is, and it's not been able to be critiqued. Right. That's a huge problem, but that's one of the things I've heard about. Bob, and then maybe get to Mike.
Yeah, thanks for your thoughtful and constructive suggestions. I want to take up on one of your points, which had to do with patient orientation, and in the question I want to include the input side of it, or the IT side as well as the output side. I know that the National Quality Institute collects data that it doesn't publish on the patient satisfaction in different provinces.
National quality, right.
And there are large differences in the patient satisfaction. I also know that in Germany, once they started collecting that data, there was a big crunch. The medical people didn't like it. But the quality of care went up after they started collecting it. Of course. Now, in the private sector, which is following some of your thinking, when there was a big shortage of IT people, you couldn't get IT people to go into the front lines and do any customer interaction. They're just too short in supply. Right. But nowadays, some of the firms, and one of the current books on it now is on car rentals and so on, you can get an IT person to go out there, face the customer, and then they write a different type of solution, you see, that's more customer-oriented. And so the question is, do you see any way, like renting a car is really simple compared to the kind of medical problems that we get, but do you see any way to get the sort of patient orientation level up to a much higher quantity in Canada than we've achieved so far?
Well, you mean the orientation of the patient or the patient orientation much more into the system?
Well, getting the system to respond to health care,
yes,
from the patient's
absolutely.
point of view.
I'll tell you exactly how, we were talking about this specifically on the seniors case earlier today. What you have to do is think of it for the minute as designing and marketing a new product or a new service, right? What would you do if you were in the private sector business building a new widget? You'd do a whole lot of market research. You'd do a lot of focus groups. You'd say to people who are going to buy this widget from you, or you hope will buy the widget from you, how do you like it? What do we have to do? What makes it work? How do you make it friendly? All of that kind of stuff. In other words, you'd get a huge amount of iterative consumer input, right? So you'd start off, then you'd talk to a bunch of consumers, in this case, quote, people who are, I say consumers, people who aren't yet patients but are going to be at some point in their lives, and then get feedback, and then you do this iterative process. So what you actually produced was something that was truly patient-oriented, as opposed to going away, which is the old way of doing things, and there's some of that now going on. I mean, Dominic and I talked about that earlier today. But the historical way of doing it would be the IT guys would go away, do their thing, come back, and say to you, okay, now you've got to adjust the way you work in order to fit my solution. And everybody gave them the finger, and they never understood why, right? And the reason for that is that it was absolutely not patient sensitive. So that is doable. That was your second question. Well, you had a first piece.
Well, I just wondered if the deliberate use of more satisfaction indices would change behavior.
I mean, I think it's scandalous that because there's certain other satisfaction indices that are floating around about the healthcare system that isn't released, and I think that's outrageous. Look, I believe that one of the biggest motivators to change is public embarrassment, right? And it doesn't cost you any money; you just need the data. I mean, it is an unbelievably powerful tool. So if you got data that showed the hospital here, which I guess is in Kitchener, right? That showed the hospital here was, and don't compare it with one of the big teaching hospitals, was much worse. Patients thought it was much worse than the hospital in Brockville or somewhere. I got to tell you, and by the way, that was covered appropriately on the front page with second coming headlines in the newspaper. The media could do its shtick. I got to tell you, that's a huge motivator. Why? Because what happens in the local community is the doctor in the hospital see you go out and somebody says, how come you guys are so bad compared to the other guys? I tell you, public embarrassment's a very, 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 and even, I think you can often get a lot by just the fear of public embarrassment. I mean, just by telling people you're going to do it can have an improvement. So if there are those kinds of things around, we absolutely ought to put them out. And it is scandalous that public money is being spent and that element of accountability is not there. I mean, the rest of us get it through what they traditionally call public opinion polls, right? So, I mean, absolutely. I think question back there?
Yeah, you've answered part of it, I think, when you were responding to Bob there, but the e-health record is essential and inevitable from what you're saying.
Right.
It's, there's no question about it. You've pointed out all the barriers very well, but what's the next logical step that's doable? And
the next logical step that's doable...
Without a lot of talking about it.
I'm with you 100%. I know I like to talk, but I'm also would like action. So
I don't mean you. I just mean the process.
No.
Everybody talks.
No, I'll tell you what the next logical step. The next logical step, and somebody up, the first lady that asked the question raised it. We need a handful of really good pilot projects that work, and then what you need in Regional Authority X, in Hospital X, whatever it is, and then you need the provincial government to say, next year's budget depends on our ability to get the same information from you. And you can debate whether that's a carrot or a stick. I would be inclined to call it a carrot. Somebody else might call it a stick. But whatever it is, you got to put an incentive. Whoever made the comment over here was dead on. Look, human beings change their behavior entirely on the basis of incentives. Sticks are okay, but they only work for a limited period of time. Carrots are much better because they last. And so I get back to saying, how would you persuade Hospital B to adopt Hospital A's system? Well, what you do is you make Hospital A's revenue, income, whatever you want to call it, dependent upon their ability to provide the same information and meet the same service standards as the other one. That's a bit of a carrot and a stick, but that's what you've got to do. And you've got to stop trying for this nirvana of a national rollout, right? I mean, let's do it piece by piece. I know there's a lady here who's been anxious to ask a question for a while.
We have one here. We have 3 questions in the back, and we have to eject Mike at 4:30. I've given us this.
Yeah, sorry, I got to give a speech in Toronto tonight, so that's
We'll have time for hopefully those 3 anyway.
Go ahead.
With our recent announcement of funding for home care, how do you see e-health fitting into using this as a partial solution?
I mean, if there was ever an area where e-health really ought to work, it's in home care, only because the same home care provider, I mean, the same individual person, often doesn't see the same. You know, the person who does home care for Mrs. Schwartz on Tuesday and Thursday, the following may not be the same person. The electronic health record is critical, and I think you'll be able to get it in home care. You'll be able to get it in home care because, frankly, they're largely either not-for-profit or for-profit service providers, St. Elizabeth's or ParaMed or somebody, and it's absolutely in their interest to do it also. So I actually think home care may be one of the big breakthroughs early on. Yeah.
I couldn't help it. I come from community mental health. I actually work in the community, cradle to grave, children and seniors. Mm-hmm. We can't wait for the acute care system, and one of the reasons our incentive, we have purchased a web-based software. We really want to try to start the electronic record, but it's quite practical. Absolutely. We did not have enough money to have enough people faxing and putting in envelopes, 100 forwarding assessments a day, so that acute care system or that family physician can actually see the information in a timely way. So we're trying to be, I'm also on e-health with Don Cowan there. We are trying to instigate it, and I totally agree with the person that said The patient-driven,
Yeah.
we tend to say client, but the patient-driven.
By the way, just since we're talking about mental health, just an aside.
Yeah.
I never use the word patient, never use the word consumer. I mean, I don't take the medical model as being the only model possible for mental health. And if you doubt that, see what some of the Aboriginals have done. And I don't like consumer. I mean, my sister lived with a mental illness for a large part of her life. She didn't go out and buy it.
No.
I mean, she happened to get ill with mental illness. So, I mean, don't try to tell me she was a consumer. That gives absolutely the wrong orientation. And what's going to happen, what you're doing and other little people like you, that's terrific, is what you're doing. And what's happening is that out of necessity, you're being forced to make changes. And also, you don't have the rigid organizational power structure that the acute care system has. Right. You're just cruising along below the radar, right? Which is why, by the way, you're also starving. But the reality is that a lot of changes, in some funny ways, more is going to happen faster out of pure necessity in mental health, which we're going to promote hugely. I'll give you an example. On telehealth, by far the most obvious application for telehealth, which is the case where the patient's one place and the doctor's the other, is mental health. It's the only part of the healthcare system where the doctor never has to touch the patient, right? I mean, it's typically a conversation literally a conversation between the healthcare provider on the one hand and the patient on the other. The fact that they're separated by several hundred miles, if you've got the appropriate technology, it has to be visual, it can't just be oral. It's a natural. So, in fact, we're going to be, and if you look at the truly embarrassing numbers in remote Aboriginal communities and the Inuit communities, I mean, just the two numbers that absolutely stagger me are the biggest cause of death Canadians between the ages of 15 and 19 is suicide. By the way, okay? And the numbers by the way, that is the third worst in the OECD world, right? And the Aboriginal and Inuit numbers are 6 times the Canadian average. So you don't think we got a problem? Okay. But that I tell you, I can begin to get a handle on that with telemental health, because I can have someone sitting here in Waterloo who's a clinical psychologist, and all they need to do is do patients that are a long way away. So out of necessity, we're going to start doing that. But anyway, what you're doing is good. I know I talk too much, but go ahead.
From Corey on the web. What do you see as areas of opportunity for interprovincial collaboration, and what are the big challenges to this type of collaboration?
Well, interprovincial collaboration is happening among the Atlantic provinces and the Western provinces. Ontario is so big that interprovincial cooperation in Ontario is really Northern Ontario cooperating with Southern Ontario. In contrast, for example, if you look at the prairie provinces, partly including BC, certain very special services, particularly, let me see if I can give you an example. Yeah, cardiac heart surgery done on very small children. Okay? There's only one center in Western Canada for doing that. And everybody has concluded it's far better to do the vast amount of capital investment, put it in one place, have the trained people in one place, happens to be Edmonton, but let Vancouver have another specialty, let Winnipeg have another one, and so on. And in a little bit you get that in Ontario, because it so happens that that specialty in Ontario is actually done at the Ottawa Heart Institute, much to the chagrin of some of the other places like Sick Kids. But the reality is that some of these things are so expensive and so specialized that we've got to cooperate. But Ontario, as I say, is so big, it's got 40% of the population. It doesn't need to do it interprovincially.
There's one quick question and answer.
Yep.
A question. Am I getting through? Okay, yeah. Back at Memorial, the group that has been involved there have been talking about electronic health record versus electronic medical record. And we have become convinced, looking at what's happening with the InfoWay project, that in fact the infrastructure that they're setting in place is more appropriate to health policy questions than it is to an actual electronic health record that is keyed to the individual patient.
I didn't know that.
And in fact, what they seem to be doing is saying the actual electronic health record is going to have to be developed by the local providers, the provinces, rather the electronic medical record, which is the continuous diary of the medical events that are happening in the individuals. And in some ways, the data that they're going to be integrating into that backbone that's going to be nationwide is going to be more of the sort of Kai-Hai data, which is involved in terms of health policy analysis and issues.
Right, and I did not know that. And look, to me, the big focus is you've got to have not the policy-driven data. You've got to have the data that helps the service provider on the ground. And I did not know it was doing that. I'm actually going to take a look at that because that's very troublesome. I mean, what you really need is to have a situation in which all the medical history of an individual, and the example I've often thought of is, imagine that you yourself have, you have had a history of being allergic to certain drugs, you've had certain other problems in the past, and you suddenly get hit in a car accident 2,000 miles from home. It would be an awful lot better for your treatment if the physician that sees you in the emergency room is able to look at that history instantly and to know, okay, this thing that looks like it may be broken is just a scar from another event. I can't give him this drug because I'm going to have a negative reaction. All of that. That's what's needed.
There may be a terminology problem here. We have to end up, but the electronic health record is meant to be that cradle to grave, and the word health means not just medical, but any.
I understand it. That's why I use health, not medical.
That's the way I call it. The electronic medical record, the proper terminology is being applied to the provider's office. In other words, that's the record acquired at the office level.
But that leads you to back into the notion of a provider-driven system. I mean, if I leave you with one thought only today, is keep in mind that healthcare is just a service business, nothing more, nothing less. Happens to be one that matters, but that's all it is. You can't run any service business if the driving variable in the system is not the customer. As long as the driving variable is the patient, is the service provider, you will automatically skew the system to the convenience of the service provider and not the convenience and treatment of the individual who's actually the customer. And that is what the system is. And the role of government in that system is purely to be the insurer. It doesn't have to be the service provider. It is the insurer that will ensure that when you go somewhere and you give them your OHIP card, you don't have to pay for it. Now, we got to get them to pay for more things than they do now, and some of us who now get things free should pay for it. But that's the subject of another talk.
Thank you very much, Michael.
Thank you.
Michael, I've really appreciated you coming here. It was a fabulous talk. I really enjoyed it. I think our audience did, both here and remotely. We'd love to have you come back anytime. And so with that, here's a small token of our appreciation.
Wonderful. Thank you.
And I hope you'll all come back and join us next month, October 24th, to hear about patient safety. Why not better patient safety? You mentioned a little bit about that today. It'll be a great talk, and I look forward to seeing you then. So thanks for coming today.
Thanks, everybody. I'm sorry I got it wrong. That was okay?